So you're a Chicagoan and you're a Bulls fan.
It's hard these days.
Right.
It was easier in the Jordan days, but yeah.
And we're in Indianapolis.
Yes.
And there's this team here called the Pacers.
I'm more.
That they actually are going now to play the Knicks in the playoffs. Who do you have? What do you think?
So it's really hard to come back to the Pacers after what Reggie Miller was doing with Jordan back in the day. That still hurts a little bit, but yeah, I would prefer the Pacers over the Knicks any day.
That is saying something.
So
here, let's hear it for David. Welcome to Boombostic Health. This is episode 26. We're doing a Boombostic Health in the Wild here, which is the first where we've actually got a live audience that's part of our Health Innovation Summit here in Indianapolis. We were at the Indianapolis Motor Speedway yesterday, where we got to hang out with our friend Jack Harvey, who's the 24 car under the Dreyer and Reinbold racing umbrella. And you'll notice that on the fenders back there, I think that's what you call them. I don't know. HC1's on there. I'm not that into cars, other than I know that it's a lot of fun to watch these guys fly around the track. But did you folks see that Jack's times were really, really good? I mean, he was up like top 10 by the end of the day. So Jack Harvey is, I think, going to have a great showing at the 500, and it was fun to get everybody introduced to him. So we've got a very valued friend and guest here in David Ohm, who is a really fascinating person. I had a chance with David last night to hear his story, which started with a whole career basically in more of the financial world, working in the pit, and heard a really fun story about his first day where he almost got into a little bit of a scuffle. But we can talk more about that. So David is the Chief Strategic Development Officer for MultiCare, which is a significant health system in the Pacific Northwest. Very happy to have him here. And we're going to be talking some about AI and data and the opportunities and challenges that exist for a nonprofit type of health system like David's. But thanks for being here, David.
Oh, thanks for having me. The whole event has been really an experience I'll remember for a long time. I've never been to the track at Indy, and that whole day was pretty special. So thanks for including all of us in that. And it was nice meeting the people out in the audience here, making some new friends.
Awesome. Yeah, it's pretty staggering when you roll up into this. You think about it being like this little racetrack, and you get in there and it's got a golf course inside of it and a music venue, and it's incredible. It is, for good reason, the greatest spectacle in racing. No question. And part of the reason we connected the dots for our Healthcare Innovation Summit with the Indy Motor Speedway is it's all about high performance, and it's all about how do you go from operating at kind of a level that isn't fast enough and isn't good enough, and tuning the knobs until you can really win. And it was interesting, in our trivia, we heard that it was 74 miles an hour was the average speed of the IndyCar in the very first race. And now the speed is like in the 234,
It's crazy.
On average for a winner of the Indy 500. And I draw the comparison in healthcare. I think that's, in many respects, we're at this like horse and buggy pace right now. And that needs to change in order to improve things for everybody, and the patients, but also the clinicians. So getting to you a little bit more, David. So just real quick, why are you in healthcare? And I know you can tell the funny version or the serious version, whichever ones you want.
Well, as I told Brad out in the other end of chamber, that my story does not work as well as his does for being poignant. But I was in a couple of other industries that kind of went by the wayside. I started my career at the Chicago Board of Trade in the pits, and the open outcry system that I was a part of ended after 150 years in practice. So
it went extinct, basically. Your job went extinct.
Yeah. So then we had to reinvent ourselves. And
was it fun going home to talk to your wife about that?
Well, she saw it coming, as many of us did. I mean, we were stubborn, thinking that we were replaceable for a little while there, and yeah, just the efficiencies of a new world taught us otherwise. But nonetheless, yeah, I've always been. I think it taught me a lot of lessons in resiliency. So I was able to figure out a path forward that was just really a lot of the lessons I learned from being down there that were challenges I faced. Just helped me kind of stay on the right track. And eventually I found my way into healthcare because it was an industry that I think I was always just found appealing and attractive. Even when I did other things, I was always attracted to the vertical of healthcare. And I actually have a background where I came through lab. As you know, I was at LabCorp prior to MultiCare. While at LabCorp, I worked on large enterprise health system partnerships, and that put me in touch with some of the concepts now that I deal with on the other side. So I feel like I've been very fortunate to be around not only wonderful people in my career, but also just kind of built up a pretty broad kind of platform to learn from. So yeah, I feel pretty lucky to be where I'm at.
So with all of these organizations, LabCorp in particular, there's a lot of data that's generated and a lot of interest in how you can utilize that. And in LabCorp's case, it's not only a clinical laboratory business, but it also is one that works with pharma and does,
Sure.
Owns the CRO kind of, or did, I don't know,
Yeah,
fun spouse, but that, yeah.
Sure.
But in any event, you've seen a lot as it relates to data, and then you've moved over to the other side where you're an actual provider and you're dealing with data on that side.
Right.
Yesterday, that was a huge theme with everybody talking about data. And I know you and I were talking earlier about this whole idea of data brokers. And, as a health system or any kind of provider, you need likely to have some external expertise to help navigate how you can take advantage of that. And also, I think it was touched on staying true to the mission of delivering better patient care.
Right.
I'd love to hear your thoughts on where do you go as a nonprofit health system that clearly there's no margin, there's no mission, and also you want to make sure that you're doing right by how this information and insight is deployed.
So I think that's well put, and it's something that we all kind of have a responsibility to do, is to at least have a passing understanding of the new world and the changing landscape around data. I'm not a data scientist, but we face a lot of headwinds in our organization, like probably everybody out here does. And like it or not, this is the horses out of the barn. There's no changing what's about to happen. So I think being educated in best how to approach the challenges we're about to face through AI, kind of its use in general, but particularly in healthcare, we need to be prepared for how to understand that as well as we can, whether it's your purview or not. You could be a chief data scientist in an organization that is responsible for enacting a program, but I think everybody from leadership down should develop a basic understanding of how to apply data, at least from a set up guidelines and a governance and, a structure around ways to keep it under some kind of format that you can control.
Yeah, well, I think that it's definitely the case that there is an opportunity to make patient care better if you use these insights in the right way. But then you start moving into this realm of what do you do about artificial intelligence? Because there's a lot of, it's not really regulated, and maybe it shouldn't be, maybe it should be, who really knows? But I'd be curious to get your point of view and even some stories or examples of where do you see AI, one, being regulated within your healthcare system in terms of the decisions on what's going to be used and what's not going to be used, and then give us an example of, hey, here's a place where we're starting to see this actually take hold.
Yeah. So I think when we were in our meetings yesterday and you had, the McDonald Hopkins folks that speak a little bit to the compliance side of it and the regulatory aspect, you're starting to see new laws come into place. In our state, in the state of Washington, we have consumer health data laws now that are helping people control the sale of the data. So that type of regulation, I think, will only increase state by state over time until maybe even nationally to some degree. The use case is dependent on subjectivity to, of course, who you are, what your needs are, what you're looking to accomplish. But from our perspective, we have actually, since 2017, we've been involved in a couple of we did a pilot with a company called Exelis. That's an appeals, streamline the appeals process through AI. And
appeals for payments?
Yeah.
With insurance?
Appropriate reimbursement. Yeah.
Okay.
So we started with them in 2017, and then there's another company called Tuva that we have a venture arm that's part of our connected care group that invested in this organization that's actually an open source platform for data. And we felt we can build off of that, even though it's open source. We didn't want something being stuck behind a paywall that all of a sudden we can use. So we thought it would be appropriate to work with this organization and develop something off of an open source platform and then kind of figure out it from there. So we jumped in a little bit. I think I would say at the early stages when you're talking 2017.
So in terms of the appeals, there's so much conversation about how messed up insurance is, right? And I know there are a lot of ways to consider why that is. And it certainly doesn't justify murdering somebody like what happened with this psycho that killed the United Healthcare CEO. It's a pitiful act. So this is an area that clearly, though, needs to be better. And in the case that you're talking about, is this actually helping patients because it's helping to make sure that things that should be covered are covered? Or is it helping the health system more because it's
great question.
I'm curious.
Yeah, it's a great question. So no, but not because the intent isn't there to eventually get there, but from an initial perspective, it's really process related. It's organizational in nature. So I think that's what you're seeing a lot across the AI spectrum right now, whether it's in healthcare or not, is there's a lot of walking before running. And even when I ask questions of people who are subject matter experts, they seem to hesitate to go beyond like scribing or scheduling or things that are really just process related versus things that are more predictive analytics and things that you can apply to the real world for true change. But I think maybe people are fearful that the proper restrictions aren't in place yet to actually take that next step. So, and that I think it's okay to be cautious with AI. I think to move slow is probably wise at this point.
So right now that technology is helping to make things more efficient. So you don't need so many people to do so much work.
Correct. It's staffing and, just operational efficiency pretty much. And you'll get into that kind of what you're talking about, the fraud, waste and abuse. And, there's software out there right now that does that. As a matter of fact, I used to work for a company that, had a proprietary solution for that, but that was an AI. It was just, a SaaS-based product. So I think AI will be responsible for much of that in the future. I just kind of waiting for that next genius.
Yeah, everybody says AI for everything now. Yeah. If you see like a form on the internet that you enter in your name and birthday, it's like, hey, that's AI. No, it's actually just a form.
Right.
So it's interesting, actually. I'm involved with a project that in large part is to better understand what AI can do. And I think people still, even so now there's the ChatGPT world that people use, and increasingly there are alternatives to that. And Google has integrated in the answers. And the thing is they're not always right, but they always sound sure. And I think that's a huge problem. Especially if you think about that in healthcare. If you go to healthcare and the thing sounds sure and you're making a decision about patient care, that could lead to a pretty big problem.
Yeah.
And so I think there's a huge opportunity, just like with ChatGPT, where you can ask it to do things. It's fascinating. Hey, draft a business plan for fill in whatever you want, and it'll spit out a whole bunch of stuff with stats and whatever. Now, I will say that oftentimes the stats are not correct because they're pulled from the wrong places. So we were having the conversation about what creates value from data. And people use this broad term data and it's thrown around, my data is valuable, I'm going to create value, whatever. And I think in reality, people are still pretty naive about what that really entails. And we've already seen this rapid acceleration of what the end users or end buyers of data are expecting. And typically it tends to be pharma is a major player in wanting, because they want to do research, they want to identify the patients that need certain medications. And to know that, you need to have access to this information. And there was a time where I think pharma was just buying data and they were comfortable with that. And these data marketplaces exist to facilitate that. And in my view, that is that race to the bottom on price type of commodity model really brings low value. And we've actually had some firsthand experience with this. It just does not end well. So I'm curious to get your take on, when we talk about data in a healthcare system, what are we talking about, right? I mean, because there's a bunch of junk everywhere that's not actually worth anything unless you put some type of value to it.
Sure. Yeah, and I think data can be generated so many places, to your point. It could be lab generated, it could be through the EHR, it could be wearables, it can be, there's so many sources for data. Sometimes even patients themselves opt in to offer up, their outcomes and so forth. And I think, to your point, that one of the things that needs to be kept into account at all times is the use case, is the value. It's not the data itself. And we're learning that there is an end game and there's the zero-sum game, that where we land with what the data value is. So I think you and I were talking out there where people overrepresent the value of their data at times just because it's data. And well, somebody needs to do the work to get to its use and its application. And that's really where the answers lie. And so some organizations will put into place data licensing agreements where those agreements basically exist between, like, for example, a health system and a tech company, and they'll apply the actionable insights that are derived from the raw data. So they're really buying the insights, not the raw data itself. And the value in that too is then the health system can keep that data in-house, de-identified but protected, where the insights are expert generated and they're still coming from a source you can trust.
Yeah, I think there's some parallels to this. What I tend to see and hear that I really take exception to, candidly, is where there's a provider or a lab that is so concerned with their participation directly in whatever potential monetization might occur of their data, or any sort of derivative or any insight that is generated at the end of the day, and it tends to be veiled in this, well, we're concerned about patients and privacy, but it's really not. It's more about, hey, we think that there's a way for us to get money, and so we don't want anybody else to be able to do that. And I think that the fallacy in that thinking, candidly, is any one individual healthcare organization, really their data alone isn't actually worth that much in these secondary use cases. It's when it becomes refined and enriched and linked, and then insight is generated on top of that. And I think about it as a parallel to me is Google. So Google provides this free service that you have used and enjoyed that has changed our lives and made it easier to get information about anything. I always laugh whenever any question comes up and we're sitting there like, what is that? And then Emily will say, if only there were a way for us to find out the answer, and we all use that for free. And the way that Google then monetizes that is using ads that are targeted. And so there's a service that's valuable to an end user that has to be monetized somehow. And I actually think that this whole data conversation, I think what providers stand to gain is tremendous innovation that they get to benefit from to deliver better patient care and have better economics in their core businesses by leaning into strategies that allow and empower others to leverage insights that can be gleaned from this unification of lots of different data sets. And there's this concept that I'm sure most folks know called tokenization, which Datavant has really become by far the leader in. And that allows you to have de-identified records that are about the same person linked in a way that really it's not going to be re-identified if you follow expert determination or you follow one of these protocols. So I don't know. I think it's like we're in this awkward dance. It's like a middle school, dance where your palms are sweaty and everybody's kind of like not sure what to say, and like the Bon Jovi song's on or whatever, and and it's like, hey, let's just get that out there in the open. Like your data alone isn't really that valuable, and you don't have the resources to make it valuable. You don't, or the expertise. And I don't say that to be offensive or polarizing. It's just like, hey, let's just get it out in the open. Let's just have this conversation and not do this cat and mouse game. What do you think about that?
Yeah, so I think, again, walk before running. I think particularly in a health system and particularly a nonprofit, the mission is first and foremost. And yes, we need to keep the lights on, and those headwinds are pretty challenging at times. Remember, health systems can only get reimbursement, through networks, and a lot of it's government payments. So it's not like we could just raise our prices. So most of it's cost reduction. But I think that's an area where it's easier to start, that an internal utilization, where if you're looking to apply AI to something, it helps to start there before you need to try to do it in ways that might feel more aggressive. So initially you might, try to figure out ways to reduce costs and efficiencies and staffing models and things where that's where AI maybe can help you keep those costs down. And that also then you develop a comfort level. And I think, you can build the infrastructure around AI and governance and so forth, and, put in place those guardrails that you're going to have.
Well, it's a good point. If you think about where the costs really are in the healthcare system, supply chain is one that comes up a lot. And you have to have legions of analysts to go comb through all this information. So that's one that you're not going to harm a patient if there's a discrepancy in the price on something that you negotiate or whatever.
Sure.
But there's a lot that you can gain that goes back into patient care. So a model that I've seen that I think is really interesting for a nonprofit with respect to how to leverage their insights and data in doing that is to have the right kind of partner and set up the right kind of structure where any proceeds that are shared back go into like a doing well by doing good type of model. So an example is you've got a lot of indigent care that you need to provide. Imagine if you had funding coming in that allowed you to do genomic testing on people who didn't have insurance, or who were coming in as people that were from an underserved area. I think there's so much opportunity. But if you can monetize this like Google monetizes search, in a really targeted, focused way that doesn't violate privacy and all of that. I mean, heck, could be amazing, actually, I think, for the advancement of patients and their care if there were like more of a more universal standard understanding and agreement on, hey, here are the rules of engagement. The Seurat painting example is one that I like to refer to because there is this picture out there that nobody can see yet. But I think once you start to see it, you'll realize, wow, we can do things to prevent disease. We can do things but at the same time, like a CFO told me very early in my career when I was all bright-eyed and bushy-tailed and saying, hey, here are all the ways we can keep the patients out of the hospital. She said, well, if we do that, what will that do to my fee-for-service revenue? Yeah. And I was just floored. And this is the CFO of a huge health system. So I don't know. I think that we have to all be realistic about what the motivations are. Incentive drives behavior. So what is the incentive for a health system, especially a nonprofit health system, to want to be in this world of leveraging their data and driving AI and all of that? You really think what do you think?
So I'll respond to that, but I first want to kind of make a comment in regard to your point around feeding it back through a foundation, because it's an excellent idea, particularly for an organization like ours. And to your point, we do service quite a large indigenous population, and we do have a big underserved community in where we operate. And so for us, you kind of briefly touched on the whole pop health, concept, where anything we can do to improve the lives of these individuals, in their healthcare through any type of analytics that help isolate disease patterns and particularly disease progression, which is something that we see as one of the main problems, taking a stage 1 to a stage 4. If we can prevent that through, wellness programs, community engagement, and then even a foundation that draws some public awareness, that's an excellent idea. And that's a great use case, for example. It's important for us to keep our population healthy. And it goes back a little bit to the value-based care side of the equation. And, frankly, there's even a financial incentive, through quality measures being met and the physicians, making, their risk-based assessments. So that, I guess that's how I'd answer it. To us, there's a great deal of value, particularly us being the kind of system that we are. And frankly, you don't have a choice.
And how many hospitals?
So we're 13 hospitals.
13.
If you're not going to embrace AI, it's just going to move on without you. I don't think we can even have that conversation anymore, whether you want to or not. It just you need to develop protocols and guidelines to assure you're doing it the right way.
Okay. Switching gears a little bit. So you're a Chicagoan and you're a Bulls fan.
It's hard these days, Brett. It was easier in the Jordan days, but yeah.
And we're in Indianapolis.
Yes.
And there's this team here called the Pacers.
More.
That they actually are going now to play the Knicks in the playoffs. Who do you have? What do you think?
So it's really hard to come back to the Pacers after what Reggie Miller was doing with Jordan back in the day. That still hurts a little bit, but yeah, I would prefer the Pacers over the Knicks any day.
That is saying something. Here, let's hear it for David for this.
I know where I'm at too. See?
Yeah, so it's an interesting rivalry, though, that history between the Bulls and the Pacers and those personalities. And, and then you had the also the Knicks Bulls thing where you got Spike Lee up there, which why in the world anybody actually cares about who he cheers for or what he's talking about?
He's still doing it.
Yeah, well, he goes to the games by himself.
Crazy.
It's so interesting. He's so into it. He goes and he just wants to focus. He doesn't want anybody around him to distract him from the game. So, well, I'm glad that you agree that the Pacers are very likely to win. And I think everybody should just get right on board with that. So back on topic with respect to healthcare and regulation and AI. So let's talk a little bit futuristic. So we're mired right now, and I know you're an operator and you know how to execute, which is what is one of your sort of best and most unique qualities. A lot of people have ideas. You know what they say, ideas are like, can I say ideas are like assholes? Everybody's got one. But as long as
you saying it,
in your case, you are all about execution. But I think we have to view a little bit out into the future to know what we should be doing today. And I'd love to hear if you could say 10 years from now, what does healthcare look like and how is data leveraged? And think about it this way. How would you want it to work for you, your family? What do you want it to look like 10 years from now? And how could we leverage this technology? Be a futurist.
Yeah, well, the reason that's so challenging is the wild card is we don't know what AI can accomplish in the time frame that we're talking. I mean, 10 years to AI is it's so long.
It's blowing the doors off of Moore's Law.
I mean, it's not just tomorrow AI would be doing something different than it's doing today. And it's not always a good thing, but it will advance exponentially beyond what we really can even understand. I do think there's a lot of things that happen in the daily journey of a patient through healthcare that is just extremely inefficient. And so when we go back to the original use cases that we would hope to have all that in place at some point are just accepted guidelines that are in place to run a proper and appropriate AI program that just takes care of most of the scribing type of work within a health system, and patient kind of scheduling, moving all the moving parts that now are handled through the human that frankly, there could be an element there that, slows down the process. Having said that, we also hope we can generate work for these individuals. I mean, the idea is not to displace FTEs. What we'd like to do is create another way they can work that can be efficient within the new framework that AI might take some of these roles and make those different roles in the future. So I would hope for that.
So do you think that there will be a humanoid nurse that comes in and looks like a regular nurse and all that, and you can only tell that it's not a human because it's got like a blinking light on the back of its head?
So the thing is, we have them now. I mean, you have robots that, do certain, functions within the hospital right now. And that's not really something that's particularly futuristic. I think what you have to balance is patients' expectations. You're there to care for the patient as well. It's not just to address the disease state, but it's the whole patient. So there might be individuals that are uncomfortable receiving care purely from that type of format.
That's a good point. I think that is a really good point, that there's this human factor. I don't know, what is that exactly, where will the artificial general intelligence be able to get to that point where you feel those feelings. And it's interesting, going way back to a startup I had that ultimately hit the wall, but it was a really interesting concept. It was called Cha-Cha. Chris Brown was there with me as well for some of that ride. It answered your questions via text. So back in 2005, there weren't apps. So you would text the question to Cha-Cha, and the answer would come back in a human way. And we saw this amazing dynamic where people started to build a relationship with this thing. So literally you would have people saying goodnight to Cha-Cha and saying good morning and asking it questions that were more like personal, some of which I wouldn't share. But a lot of it was like, what you would ask your friend, who's Justin Bieber dating, or that kind of thing. So we were really onto something interesting. So even something as basic as a text interface had this emotive quality. I think that is a really important, a fundamental question is, will it become the case that people develop relationships in a way that fills that need, that human need? And will there ultimately be like a, AI God model for healthcare in more of the general sense, where you interact, it asks you questions and you give it answers? And it's pretty fascinating. I think probably a lot of that is going to happen, but I think it'll be the case that it'll give the caregivers, which there is a shortage of, more opportunity to help more patients and to raise the bar for quality overall across all of healthcare. I think that's what will ultimately happen with this marriage between AI and humans.
Yeah, I mean, there's every conference you go to, burnout is one of the things that, is overriding topic, and between clinicians and nurses. And it's a real thing that could be alleviated to some degree by application of, these type of.
One more comment I'll make as well, going back to the insurance issue. I do believe that we will have a future where patients are not surprised by what they have to pay for their care. And I also think that it will be the case that the providers will get to the point where they aren't surprised by what they do or don't get paid for. I had a brief stint in the teleradiology business, and I'll never forget that first time that Medicare had whatever reason that they didn't send all the money. And then you have physicians who expect to get paid the money. And it was just such I think I've learned a lot through the School of Hard Knocks. And that was an example of that. So hopefully everything becomes more clear, more transparent, more predictive, and more effective for patients everywhere. So I'd be curious to hear any closing thoughts you have about what do you see as sort of immediate opportunities for healthcare innovation that really is going to take hold next for maybe you and what you're doing?
So I think I wanted to kind of hit that first point you referenced, where one thing I'd like to comment on is for the same reason we depend on the advancements of the machine learning side of AI to consistently make it better without our intervention, is also the same reason we need to be cautious and careful that the expert human element into that input stops being primary and becomes secondary. So I think that's the overriding piece that we need to protect. And I think you made a point, we were talking about synthetic data, where there's a point where synthetic data is great for public health initiatives and things where it's broad spectrums that it could be applied in a broad way of vaccinations and so forth. But at what point, as you water down the data more and more through these large data sets, does it become less valuable by having no real world data in it anymore? So you just need to protect the source. And I think, and I'm worried about that, to be perfectly blunt. That's something that the guardrails will help with, I imagine.
Yeah. Well, and you make me think about also the fact that there's such a huge amount of information that's coming at caregivers all the time, and there's no way for them to keep up to speed on all of it. There was a study done that said if a clinician was able to read 27 hours a day, they could continue to stay up to date on all of the new information that was coming out to support delivery of care. And there aren't 27 hours in the day last time I checked. And nobody's perfect in terms of being able to read constantly, and then you have to provide patient care. So perhaps this is that way, this AI initiative that we're talking about, this future state, where you actually have the ability to be up to speed on what the latest and greatest is. And maybe that gets care, the right kind of care to people faster. And we talked about this in the oncology sense, where we and our friends from Diaceutics are here as well and talked about this, where you've got people who are getting tested for some type of biomarker, and it shows up that they should have a certain treatment, and their clinician is used to a certain existing, pre-existing protocol, and they'll put them on the protocol before the result even comes back, or they get the result back and they don't understand it. I think that is an obvious gap that the technology will definitely close, which is great for patient care.
Yeah.
And just the blocking and tackling of cleaning up the mess with supply chain and dealing with sterilizing rooms. And I think there's a whole litany of opportunity.
I would agree.
So, well, thanks, David Ohm, for being here on Boombostic Health. We are now going to have the verdict with Emily. We'll talk about some of the legal and regulatory issues in more specific terms with leveraging data for good. Thanks so much, David.
Thank you.
Well, welcome to The Verdict with Emily, where we've just had David Ohm as our guest. And David, it comes from a nonprofit health system, MultiCare, up in the Pacific Northwest, where they've got a lot of data and a lot of patients that they need to take good care of. And there's this issue around the regulations that pertain to using data in the health system and how you can use that to drive the right kind of value, and how you can avoid the sort of pitfalls that can exist when you maybe mishandle that. And Emily, I know we've talked about this, and one of the things you brought up recently, you and your partner Liz, was this issue of the data being an afterthought with respect to these contracts in historical terms, and now it's becoming more like front and center. What are you seeing in health systems that want to be more progressive and innovative, but also want to make sure that they do right by whatever those terms and conditions are in their contracts?
Sure. So historically, people have just signed vendor contracts, data rights contracts, because they took the position that they were standard terms and conditions. And so nobody ever reviewed them, and they just signed them and went about their business. So we are seeing a significant shift. Folks are actually taking the time to review those contracts to see what their data rights are, who they've given rights to, who owns their data. I think a lot of this, we started to see this change after Change Health, not to use the word change too many times, but, after the change.
It could be like a drinking game.
It could be.
Drink every time you say change.
Okay, change.
I don't have it. Oh, I have coffee. All right. So yeah, after Change Healthcare, though, had this massive data breach.
It impacted just about every provider in the country. And for the first time, we had folks come to us and say, we haven't really looked at this contract, and we signed this 10 years ago. What can we do about it? So I think it is critical now, more than ever, to take a look at your contracts. Crystal's going to talk later today about mergers and acquisitions and how this can impact the diligence process, but making sure your contracts say what you want them to say now before that can disrupt either future business operations or an M&A transaction, and certainly updating them to make sure they comply with law. I mean, David talked about state law. State law in the privacy world and security world is changing nearly daily. Sometimes it feels like hourly, right? So you can't just sign a contract and then forget about it. You need to go back and revisit those.
So there are lots of different constructs that relate to data protection. There's HIPAA, there are business associate agreements, and I think a lot of people and others, and there are a lot of folks fail to really understand which of those apply. Like,
Sure.
Could you just give a quick overview of that?
Yeah. So with data, it gets complicated. So HIPAA only applies to protected health information. When data and technology vendors are using data and hospitals are using de-identified data, it's no longer protected by HIPAA anymore. Once it becomes de-identified, it's no longer PHI. We're not dealing with HIPAA. We're looking at state privacy regs, FTC considerations, contractual considerations. I think the thing that people don't think about enough when looking at these types of agreements is there's also IP concerns, right? It's intellectual property at this point. Who owns this? What is the value of it? What can I do with it? And so it is far bigger than just HIPAA. In fact, I would say HIPAA only applies to a little bit. Oftentimes we get clients who come to us and they're like, oh, well, we signed a business associate agreement, so we're good. And we're like, well, to my previous point, that only applies to your PHI. What does your SaaS agreement say? Your data use agreement? What is the intention of the parties with respect to the data? So it is a very complicated process. Oftentimes the contracts that are signed at the same time relating to the same, underlying services are at odds with each other. And so how do you rectify that?
Well, I know that de-identification is a really critical issue, and it's one that requires third-party review. There's the concept of expert determination, and then there's more of the version where
Safe harbor.
Safe harbor, there you go. Could you talk about what's the difference between those?
The safe harbor is when you strip all of the 18 identifiers that are specified under the HIPAA rules. So you take all of that data out, and that is when it's considered fully de-identified under the safe harbor. If any one of those 18 identifiers remains, then it's not considered de-identified unless you have an independent expert come and assess the data and determine the likelihood that anybody's individual identity could be discerned from the data. If there's no likelihood, then you can say it's sufficiently de-identified for the purposes of whatever you're using it for.
So how does, as AI shows up on the landscape, how does that change what you see the future of how these agreements need to be structured? Because now you're dealing with not just, hey, we're going to de-identify the data and use it for some purpose, but you're dealing with, hey, we're going to actually train models that then gain value through the impact they can make, but ultimately they're not continuously using your data necessarily. It's just getting trained. And is it even really your data by the time it gets to that point? And is it better for everybody if we all came together and said we want to make the smartest models? Like it's such a multi-layered thing. It is. Do you have any crystal ball?
Zero crystal ball. I wish I did. Attorneys, we get asked that question all the time. I wish I had a crystal ball. It is super complicated and it's messy. I don't think there is a tremendous amount of case law yet to establish some sort of precedent in this space. I'm sure it's coming soon, but yeah, I don't know. I think we'll have to wait and see.
Yeah. Well, what I've seen just firsthand is, and this is absolutely an overt plug, but McDonald Hopkins does a great job with this, and you do. We've had a lot of these conversations about how can you approach this issue about data in a way that isn't going to block off the innovation. I think that's the one thing that has happened with HIPAA is it's been used as this reason to never use data for anything. And it goes back to the Nemo thing, if nothing ever happens to him, nothing will ever happen to him. It's like, if we never actually use any of this, we'll never actually improve anything.
Right.
And so we need to strike that balance. And I do think as it relates to counsel, I jokingly somewhat say we have some people that are enablers of progress in the legal profession and some people who are just flat out deal prevention squad. And that doesn't benefit anybody. So I think to the extent that there is a way to start standardizing on these constructs, and maybe that's something that we should do. We should have a whole Boombostic Health episode where we bring in various folks and constituents to help us say, like, what should be that standard so that it doesn't have to also be the reinvention of the wheel every single time you go back and look at a different contract.
Yeah, I like that idea.
All right. Well, you heard it here first. That's going to happen now since we said it. We put it out in the universe. So, well, thank you so much, Emily. I know that you always bring a lot of great points to the table here. And I have been told the only reason many people even watch this is because you're on it. So thanks for joining another episode of Boombostic Health in the Wild, where we featured David Ohm and talked about this very exciting and also challenging issue of how you can apply data effectively. Look forward to seeing you next week on our next episode. Thanks.